Bismillahirrahmanirrahim. Dear viewers, Assalamu alaikum. I am Abdul Jabbar Shaheen, former member of Punjab Public Service Commission. This video compiles various interrelated questions posed by different PPSC boards across different stations and dates. I've just put them together in a sequence for your convenience. So let me make at the very outset one thing very clear to you, that there were always a ripple effect of questions. The technical experts did not stop at one answer. They would usually drill down with the follow-ups. Your answer would pave a way for the next question. And the shallower knowledge would be exposed. So, today's first question is about a term which is triage. I have often heard even the senior doctors pronouncing it as triage. It is not triage. The correct pronunciation is triage. It is a French word. Now, what is triage? This was the first question. This is the first question, not the first question asked by the experts, because I have sequenced the questions like this, that I have put it at number one. So, what is triage? Triage is the process of prioritizing patient treatment based on the severity of their condition and survivability, especially when resources are limited. It is a critical first step in any emergency department or mass casualty incident. Well, the next question, as a follow up to this question, was what was the goal of creating this system, this process of triage? Well, the goal was to do the greatest good for the greatest number of patients, to treat those first who have life-threatening conditions, manage them immediately, improve survival rates, and optimize the use of staff and equipment. Then the next entry was a scenario was presented to a candidate that 4 patients came to the hospital and they had the following conditions: an unconscious child with a head injury, 1; 2, a man with a profusely bleeding arm wound, 3, a woman with a simple fracture of the leg, 4, a middle-aged man who is not breathing. How would you triage these patients, these 4 patients? Now, most of the candidates could not answer correctly. Now, let me explain it step by step. Step 1 is to perform a rapid initial assessment of all the patients to assign priority. The man who is not breathing requires immediate life-saving treatment. Airway management, CPR, He is to be tagged red because he will immediate. The next priority is the unconscious child with a head injury. he is also to be tagged red, but he is the next priority because he has a compromised airway and he has a potential for raised intracranial pressure. And then the next priority is the man with a profusely bleeding arm. He requires immediate hemorrhage control. And then the last is delayed, urgent but delayed. The women with simple leg fracture is to be categorized as yellow tag. The next entry is what is the standard color coding system used in triage? Number one is red, which is immediate. Patients with life-threatening conditions, they are to be tagged red. Two, yellow, urgent, but can be delayed. Serious injuries, but stable for the moment. Then is green, non-urgent. The walking wounded patients who can wait for care. And four is black, unsalvageable or dead, deceased. Dead are having injuries incompatible with life. They are to be tagged red. Then the next up is what is the historical background of the term triage? Well, I I vividly remember that every candidate failed this question. Triage is a French term. It has been derived from a French word trier, T-R-I-E-R, trier, which means to sort, to sort. It was introduced by one named Larry, who was surgeon to Napoleon Bonaparte. And it was major shift from earlier practice of treating high-ranking officers first. So, severity of the injury, urgency of the treatment needed, and survivor probability were the criteria of triage set by Larry, the surgeon to Napoleon Bonaparte. So this is the background of this term triage. The next follow-up question. Could you explain triage step by step? Now, the first step is initial assessment, initial rapid assessment. And the second step is primary survey. What is primary survey? A, B, C, D, E. And you know what is A, B, C, D, E? Airway, breathing, circulation, disability, and exposure. And the next step is to assign priority. Red tag, yellow tag, green tag, or black tag. Then the last step is reassessment. You have to do reassessment. Another follow-up question was triage is dynamic, not one-time activity. Explain. Now, the answer is a patient's condition can change. He or she can move from yellow to red or vice versa, or from green to yellow, or from yellow to green. So it is dynamic. It is not a one time. one-time activity, you have to reassess again and again, which is called re-triage, which is very essential. Now, what are the limitations and criticism of triage? The first is a risk of misclassification. There is a risk of misclassification. You may classify a patient as yellow who is actually red. There is emotional burden on doctors. You will agree with me. There is a lot of emotional burden when there are so many patients with critical conditions. Who is to be put on ventilator and who is not to be put on ventilator? So that is a great burden on the doctors. Then ethical conflicts. Then is legal implications. Then is bias, age, disability, social status. So these are the limitations of this triage system. Then, dear viewers, next topic around which I have compiled these questions which were asked at different stations on different dates by different experts throughout my tenure, that is GCS, Glasgow Coma Scale, or AVPU. Okay, I'll explain what is AVPU. It's equivalent to GCS. Now, what is GCS? Glasgow Coma Scale. You know, it is a clinical scale used to assess the level of consciousness in a patient, especially after head injury, ICU conditions, stroke, or trauma. The next follow-up question was, when was introduced and by whom? Well, it was introduced by two scientists, Graham Teasdale and Brian Janet, in 1974 at the University of Glasgow. Next up is, what was the purpose of GCS? Why was it introduced? It was introduced to create a simple, reliable, uniform method of assessing consciousness. Up next is, what does GCS check? It checks three things. Number one, eye opening. Number two, verbal response. Number three, motor response. So eye opening E, verbal response V, motor response M, EVM. So it checks EVM. Up next is, what is the total score? Total score. Now, what is minimum score and what is maximum score? Minimum score is 3, which is deep coma. And maximum score, Glasgow coma score, maximum is 15, fully alert. Our next entry is, how will you assign score to eye opening? Well, if it is spontaneous, you will assign 4. The score will be 4. The patient opens eyes naturally. That is the best score you can assign. That is 4. And opens eyes to voice. 3. Opens eyes to pain. I mean, needs a pin. You prick, and that is 2, which is worse. Then no response, you assign 1, worst. The next, assign score to verbal response. Verbal response. Oriented, mean he knows name, place, and time. Good orientation. 5. You will assign 5. In the eye opening, the best was 4. Here the best is 5. Confused. His verbal response is confused. You will assign 4. And if he speaks inappropriate words, utters inappropriate words, you will assign 3. And if the patient has incomprehensible sounds, the score assigned will be 2, bad. And number 5, no response, 1, very bad. Next up, assign score to motor response. 1, obeys commands, best. 6, you will assign 6. Number 2, localizes pain. You will assign the score of 5 to this patient who can localize pain. What do you mean by localize pain? Tries to remove the painful stimulus. And next, withdraws from pain. You will assign 4. What do you mean by withdraw from pain? Pulls away from the pain. If you prick, the patient will pull away. Then is abnormal flexion. Abnormal flexion, which is decorticate. Abnormal flexion. Arms towards chest, like this, inward, inward. This is abnormal flexion. It is also called decorticate. You will assign 3. Then is abnormal extension, decerebrate, straight hands, straight arms, straight legs. That is a very bad condition. You will assign the score of 2. And the patient who has no response at all will be assigned 1. Now, how do you do total GCS evaluation? Total GCS is E plus V plus M. Eye opening, voice response, motor response. Add all 3 scores, you will get the total GCS. For example, if you assign 3 to the eye opening and 4 to the verbal response and 4 to the motor response, what is the total score? Total is 11. If you are assigning 3 to eye opening, that is to voice, the patient opens eyes to voice, you will assign 3. And verbal response, you assign 4, that is confused speech. And if you assign 4 in case of motor response, it means the patient withdraws from pain. So the total score is 11. Now, you must be knowing that 13 to 15, if a patient has a GCS score of 13 to 15, this falls under mild category. And if it is 9 to 12, it is moderate. And if it is less than or equal to 8, very severe. The patient may be in coma. Here you require intubation. Intubation is must. Okay. Next up is, can GCS be 0? No, maximum is 3 because at 3, the brain is dead. Okay, why don't you measure GCS alone? I mean, why does it require clinical support also? Because it does not show you the cause. GCS is an assessment of conscious level, but it does not show you the cause. So that needs clinical correlation. Now, a scenario was presented to a candidate that a patient opens eyes to pain. Listen carefully. A patient opens eyes to pain, makes incomprehensible sounds, and shows decerebrate posturing. What is the GCS? A patient opens eyes to pain. 2, makes incomprehensible sounds. Verbal response. 2, incomprehensible sounds. And shows decerebrate posturing. Very bad. Motor response. 2. 2 plus 2 plus 2. 6. What does it indicate? Severe brain injury. Hope I am clear about this. The next and the last question of today's video is, why intubation must be done at equal to or less than 8 GCS? Why it is must? Number 1, to maintain airway, to prevent airway blockage. Number 2, to help breathing, ventilator. Number 3, protect airway, prevent aspiration, vomit, fluids entering lungs. That is, these are the 3 causes, these are the 3 reasons for which you have to do intubation when your GCS is equal to or less than 8. So, dear viewers, I conclude here. I hope this video will help you, and my next video, maybe tomorrow or day after, uh, will come, and it will be with a different set of interrelated questions. Thank you very much, and Allah Hafiz.